test. هلا هذا اللابس بدلة يمكن سبيكر، نبي سبيكرز يبينون.
رائد هو رائد صح ولا لا استاذ رائد؟
انت هذا؟ طب احنا نبي نشوف سبيكرز، ليش نشوفكم انتوا؟ انتوا شايفينكم هنا، نشوفكم هنا مرتين. طيب الاخوان السبيكرز ما نشوفهم when they speak we need them. طيب يلا احنا نطلب منهم يفتحوا. نقول بسم الله، نبتدي. قلت لا بشوف سبيكرز حقوني، نقول لهم بليز سبيكر يفتح كاميرته، نبي نشوف السبيكر.
اذا في احد من الناس
هو ايش اسمه السعودي هذا؟ يونس. بس قولي له يا سمر دكتورة ليلى نيدز بيرميشن.
يعطيكم العافية دكتورة فاطمة، كيف حالك؟
السلام عليكم، كيفك يا
ليلى؟ السلام عليكم، كيف حالكم؟
أنا يعني ما
أنا صوتك راح دكتورة، بس بدي آخذ، ما في بيرميشن عندي أفتح الكاميرا، الصوت أوكي.
هالحين نعطيهم الأخ يونس هلأ حيكون معاكي، نفتح
تمام.
النافذة للكل.
تمام.
سمر تعالي على يميني. يا يونس صارت 2 ودقيقتين والسبيكرز حقوني ما عندهم أي برميشن يطلع صورهم، أنا أبيهم يطلعوا.
أوبن كاميرا بس هم يا دكتورة. شفتي دكتورة ليلى قالت أعطيني صلاح على طول يتكلم.
دكتورة ليلى.
نعم.
من عندك افتح الكاميرا.
إيه عم بقول you cannot start, the host has stopped it.
لا لسه احنا ما شيرنج، لسه ما بدينا. افتحي just open your camera.
على الطاحون أنا داخلة.
اي افتح الفيديو.
ما عم بفتح دكتورة، مش راضي.
اوكي طيب we start وبعدين البنات will solve your problem.
ما في مشكلة.
دخلتي من لينك الحضور ولا من اللينك اللي أرسلوا لك إياها البنات؟
اللينك اللي بعثتوا لي إياه آخر واحد. أدخل
على الإيميل؟
على الإيميل نقلته، بس من إيميل تاني دخلت عليه، إيميل المستشفى.
دخلت من إيميل ثاني.
ممكن تدخلي من نفس الإيميل يا ليلى؟
الجيميل نفسه اللي تمتاي.
بليز.
أوكي. المشكلة
وصلك قبل ساعة يقولون.
أنا دخلت منه بس بعته فورورد على إيميل تاني.
أي ما في مشكلة. لا.
لازم نفسه. طيب دقيقة هلا بحاول أفتح منه. أوكي.
من إيميلك يا ليلى بليز.
أوكي.
I think we start. أنتوا متأكدين الدكاترة معانا؟ البارتيسيبنت شايفين كم ولا لا؟
هلا إذا ممكن ما يفتح من الإيميل نفسه، أفتح الكاميرا من الموبايل.
أوكي ممكن، بس كيف تعملي السلايدز؟
السلايد بخلي شير على هذا. هلا قلت.
ممتاز. أوكي ممتاز. طيب اسمحوا لنا نبتدي ولا اور سبيكرز جاوا؟ بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. زملائي وزميلاتي الكرام متحدثي هذا الملتقى، زملائي وزميلاتي الحضور الكريم، السلام عليكم ورحمة الله وبركاته. في البداية اسمحوا لي أن أعبر عن سعادتي بلقاء اليوم بهذه الوجوه التي اشتقنا لرؤيتها، فلكم مني ألف تحية. سرطان الثدي سرطان الثدي في الوطن العربي ليس ببعيد عما يحدث في العالم كله، وبتزايد مستمر كما تشير الإحصائيات. جهود كبيرة بذلت في عالمنا العربي على مستوى التثقيف ونشر الوعي، وجهود كبيرة بذلت لتوفير وسائل الكشف، ولكن للأسف ينقصنا الكثير في البحث العلمي المتخصص في هذا المجال بمنطقتنا العربية. معظم الجهود التي بذلت في المنطقة العربية أتت متزامنة ما بين عامي 2005 و2009. اليوم في هذا الملتقى نلقي الضوء على الإنجازات التي تمت منذ ذلك الوقت وأهم التحديات التي واجهتنا جميعاً. أتمنى للجميع وقتاً مليئاً بالفائدة، والشكر الجزيل لكل من لبى دعوتنا ليكون جزءاً من هذا الحدث ويثري معلوماتنا جميعاً. الشكر لكل القائمين على هذا الملتقى، وبدونهم لم يكن هذا ممكناً. وحابة أن أقدم بالشكر للدكتورة أفنان. دكتورة أفنان هي أستاذ مساعد واستشاري أشعة ثدي ورئيسة وحدة الثدي في مستشفى الملك فهد الجامعي بالخبر. والدكتورة رؤى القويز، وهي أيضا أستاذ مساعد واستشاري أشعة ثدي وناشطة في الكشف المبكر عن سرطان الثدي. تعلمنا درس كبير من كورونا، أن الحياة لن تتوقف وأن الإرادة تغلب الصعوبات. ختاما، شعارنا هذا العام للكشف المبكر في المنطقة الشرقية هو الاتحاد قوة من بين مقدمي هذه الخدمة، وهم جامعة الإمام عبد الرحمن بن فيصل، جمعية السرطان السعودية، وشبكة الدمام الصحية. أتمنى للجميع حضوراً ممتعاً وأن يكون اتحادنا مثمراً، والسلام عليكم ورحمة الله وبركاته. سنبدأ الآن الفعاليات. دكتورة أفنان تقدمي الفيرست سبيكر.
السلام عليكم. Our next speaker is Leila Abu Tahun. Dr. Leila, she is a breast cancer leader in Jordan. She is a director of breast imaging unit, Department of Diagnostic Radiology, King Hussein Cancer Center, Amman, Jordan. She will speak about breast cancer screening in Jordan. Please welcome Dr. Leila.
السلام عليكم.
سلام. تفضلي دكتورة.
First of all, I would like to thank Dr. Fatima for her really efforts and support for the efforts done in Saudi Arabia and also in the Middle East. These are well recognizable. And thank you very much for inviting me for this conference. Can you see my screen now?
Yes.
Okay. So it was my honor actually to come to Saudi Arabia in 2014 and talk about our experience in breast cancer screening in Jordan. And that's why I'm happy again now to follow up with all the colleagues in the Middle East also. The outline of my talks, I will give a few words about Jordan and breast cancer in Jordan. And I will mainly talk about our experience in KHCC, which is a representative of the major bulk done in Jordan and the Kingdom, and also the efforts of Jordan Breast Cancer Program. The Jordan demographic, we are about 11 million people. And as you can see, the life expectancy is about 70 years. So it's relatively less than the West, but the average age of the woman is 76 years old. And as you can see, also male to female ratio are almost equal. So at certain time of the age, we will have the same number of male and females. And in general, there's a trend of population increase in Jordan. So we expect the number of women also increase in the different ages too. What is the breast cancer situation in Jordan? I will go, this is the latest data from the Jordan Cancer Registry. As you can see, there's about 1,260 cases. And as I always like to talk on this slide, if you see the next second common is a 300 cases, which is the colorectal cancer. So this really means that the number of breast cancer cases is a significant issue in Jordan, because 1,260 cases, you can 60 cases, you can think about the families, women at this age are being exposed to cancer. And the next is, as I said, is less number. If we take also on the number of most common cancer in male, it's also about 300 cases. So breast cancer in women remains the main issue in Jordan. You can see the trend of breast cancer over the years. Definitely statistics has improved over the past few years, but the number is increasing gradually. And this is, it's almost, the trend is almost going steady. We're expecting the same numbers in the coming 4 years too. If we look at the age group, there's a general idea that the number in less is in women less in younger age as compared to international data. And we can see there's really a significant number of women between 40 and 49, between 50 and 59 age. And still we have a peak also between 60 and 70 years of old. And we are also seeing cancer in young female patients less than 40 years. And this is the stages. These are from two sources, actually, 2011 and 2015 from KFCC. And we can see we have few cases which are in situ stage, and we still, about 3/4 are in the, there's the less cancer in situ stages. This is about 5%, then stage 1, stage 2, and then we still have a large number of stage 3 and 4. If we take the cases which are being treated in our center also, this is also the largest number is breast cancer cases. We treat about 1,000 cases per year. This was the largest number in 2017. We had many people coming from the region also. So the summary of these talks so far, that breast cancer in women is a significant issue in Jordan. And in males, we have, it is less. Like, for example, we have 1,200 cases in female, and we have about 20 cases in male patients. So this was the idea to establish King Hussein Cancer Center. This is the old building. It was established in 1997 under the King Hussein, Allah yarhamu. He decided to open the center to treat cancer. He felt that there was an issue with dealing with the cancer patient. It was called Markaz al-Amal lil-Sartan. It was called the Hope Center in 1997. But recently it was changed the name because the King Hussein himself died of lymphoma. As you know, so did the King Abdullah and his wife Queen Rania decided to rename the center and call it King Hussein Cancer Center. This to emphasize the idea that we should not be afraid of the word cancer and that we can treat it. And now it is known as King Hussein Cancer Center. Since 2007, I joined KHCC, and it was the vision of the administration, part of the, because they were seeing the large number of breast cancer, to establish a breast imaging unit. And it was really exemplary in the region. At that time, we had one mammography machine, one ultrasound machine in the old building. And this has now expanded the units of breast imaging. So we have now three locations where we have early detection separate unit, and we have the diagnostic clinic and the 2 diagnostic clinic actually. This is to cover the services of increasing breast cancer efforts. And I always say that if you want to perform screening, you have to have a comprehensive breast imaging services. You have to cover the whole spectrum. And this was fulfilled as in our center, that we have the whole spectrum of diagnostic services. If you are doing screening, you cannot leave that patient at one point with a finding which you cannot continue. So now the services had significantly improved in Jordan, in our center. And the center is recognized for many certificate international awards. And I like to say that one of the efforts done in Jordan was to establish a specific certification for the breast imaging unit. And this had given an advantage to the breast unit that it was in focus. So as a breast team, you could ask for certain things which would not have been visible if it was part of the whole accreditation of the whole hospital. Now, of course, our efforts are definitely supported and the whole put together with the effort of the Jordan Breast Cancer Program. The Jordan Breast Cancer Program, these slides are shared from Dr. Reem Al-Ajloni, the director of the Jordan Breast Cancer Program. It is governed and led by our institution, the King Hussein Cancer Center and Foundation, and with the support of the Ministry of Health. The idea that they had conducted situation analysis, and it was realized, it started in 2007, that we have, as I said, some late diagnosis of cancer, inadequate infrastructure, a lack of standardized care, there's shortage of trained healthcare provider, limited awareness, and fragmented efforts. So there were some centers doing some mammogram for screening, others were doing some diagnostic. So the main aim of GBCB was to reduce mortality from breast cancer by shifting the stage toward early diagnosis. And these are the, let's say, the themes where they worked about. Service delivery, they worked mainly about the infrastructure and building capacity regarding the staff, regarding the equipment, and to enhance the so-called opportunity screening. So they were giving like campaigns, giving support for the woman to do mammogram, which is free of charge with the cost of the biopsy, and this was really encouraging. I will show some examples now. And regarding the quality was establishing a guidelines, and I said as the accreditation, establishing for the best unit itself. Social marketing, this whole slide is another big talk by the GBCB. They can share their expertise and consultancy with other countries who will need help in the outreach, the mass awareness compound, the training, and the advocacy and support for the woman. Of course, the process which is going, and Dr. Fatima mentioned that we still need to have more data and research, and this is actually limited, I think, in many people in the region. The infrastructure, what they supported units, they give like a machine, they support by the redecoration, painting, hiring staff, and this is about the guidelines. The Jordan Breast Cancer Program, together with the task force from KHCC and the institution in the Kingdom, we started to develop guidelines for screening and diagnosis. We developed a mammography manual for the technologist and the clinical breast examination manual. These are based on international guidelines. For example, the guidelines on this one is based on the NCCN guidelines. Education has played an important role. We have developed many workshops and covering different aspects, radiographers, radiologists, biomedical engineers, quality control engineers. And one of the important things, I think, which had added number and team trained staff to the region, as well as recognition of the breast imaging fellowship by the Arab Board of Health Societies and Arab Board in radiology, because this the previous efforts, when you do just some workshop and training, this will really enhance the knowledge. But once you have a specialized trained radiologist who have expertise in the breast imaging field, this really enhanced the efforts. And of course, they started the awareness campaign. Awareness campaign started in 2007 in Jordan. It really had an impact in the overall idea of breast cancer awareness. The women are becoming now by themselves to do mammogram. They now do self-exam and they will feel masses. The awareness, this was really enhanced the knowledge about the breast symptoms, what to do, where to go. Still, the issue which we are facing, still women are afraid. They are shy to go. We always focus on the idea that we have female clinicians, female radiologists who you can seek advice from to avoid some of the challenges which was met before. And before almost 2015 started the الحمل الناشونال على مستوى الوطن العربي كله, the Arab countries, where Saudi, I know, is part of it, and many other Arab countries together using the same theme. And this has really had its advantage and impact. And as I said, as Dr. Fatma also mentioned, that we need to have more research from the area. So having a national mammography database is an issue. And this has been supported by the Jordan Breast Cancer Program, and they are working on it. They have established now a software to collect the data. And probably this will help to gather information, and this will be a good material for research and knowing what's really happening in our region of the world. Now to share our best, as I said, the KHCC Breast Imaging Unit is an example for the country. This to show the number of cases we are performing, the wide range. As you can see, the number of cases has increased over the time. So in 2019, you can see we perform about almost 29,000 exams, including the wire, the procedures, the biopsies, all the mammographic examinations. And this is the number of mammogram, and you can see also the trend over the year. The number of mammogram cases performed in the unit has increased all the time. This is the corona year. I think the drop was expected even more. We continue to do during the corona period the diagnostic cases mainly. We stopped the screening for about the peaks time. the total will be about almost 2 to 3 months in different regions of screening, and continue to gradually. And the number is 2021 now is increasing again. And if you like to mention about your efforts, I will be sharing the cancer detection rate among cancer cases in our center. This is actually a limited sample of only cases coming to the early detection clinic. And we can see the cancer detection rate among screening is about 2%, which I think it is considering country as a Jordan with the increasing number of awareness and the more women coming to screening. I think this is a good number if we can have 2%. Our target was to reach larger number of screen detected cancer to be like 10%, but this is the efforts we have done so far. And the other thing to reflect their work is how many small cancers you find in any screening. So we looked about these cases which are screen detected, which one of them was a small cancer, less than 1 centimeter invasive ductal carcinoma or DCIS. And this also shows the trend over the years. And this is showing that the number is increasing. So this reflects the efforts of screening done in a country. If you're having more cancer detection rate from screening, of course, and a minimal cancer detection rate, because this will shift the stage, which was the aim of the GBCB at the beginning. And another issue which was also supported between King Hussein Cancer Center as a medical arm together with the Jordan Breast Cancer, it was the mobile van mammography. At the beginning, it was for Jordan with a small population and limited resources. We had issues like, is it going to be a successful story or no? So we started with the 2 mobile vans. We still have 2 mobile vans, and we started to cover the area. I will show with you the experience. We have full field digital mammography in 2 machines, in the 2 mobile vans. We covered all now 7 cities or governorates in Jordan, and started mid-2012, and it's still ongoing. So this is the total number of mammograms done in screening mammography. At the very beginning, when our first 2 projects, actually it was in these 2 cities, it was our first experience. I remember that time we shared our experience in Al-Ihsa. And we had issue with accepting diagnostic cases in the mobile van, because these were in the periphery far from the city Amman, and the woman will come when they knew there was a mammography. So they will come with their mask or lamp and they want to do the mammogram. At the beginning, we were accepting them there because it was really an issue not to send them to Amman, maybe they will not come. But after that, we stopped doing this because actually they are closer to Amman, the other city, and we managed to give the woman so-called voucher to give her financial coverage to come to KHCC to do her diagnostic workup. And this, of course, was much beneficial because anyway, you have to do the ultrasound, you may do biopsy. We try to even do at the same time whenever we can to fit her in if she is well. And the cancer detection rate from screening mobile mammography was about 8 per 1,000, which I think this is also within numbers, international numbers. If we take average all the cities, despite the different number of screening mammograms done in all cities. The stages of screen detected cancer, again, from the mobile van, it also reflects an increased number of stage 0 and stage 1 and stage 2, which is good. But still, as we can see, we still have stage 3 and 4 among screen detected cancer. So we have some cases which come with positive lymph nodes already some evidence of metastasis soon. So really, the more efforts will be spent to increase screening efforts in the kingdom and to increase screening detection, detection of small cancer to avoid these late advanced stages. And interestingly, we review some of the cases which continued treatment at KHCC. There were invasive ductal carcinoma was the most common found, DCIS, we had a few cases, lobular carcinoma, and we had lymphoma cases from the mobile van. And I will review as a radiologist just a few cases which we have seen through screening mobile mammography and our expertise here. As you can see, this lady was 70 years old. So in our experience that the women are willing to do mammogram regardless of the age, because they had the facility when they had the van there and available next to them, even 70-year-old women were coming for screening mammography, like this case. And you can see that we could see a small cancer. And I always emphasize that if you are doing the screening mammography, you have to have the comprehensive whole spectrum of services. So you do ultrasound, you do biopsy, and this is invasive small ductal carcinoma 10 millimeter. So this is really the aim of screening mammography. This is another case, 69-year-old. And you can see very faint calcification stereotactic biopsy was performed, and this was also low-grade DCIS. As I mentioned, interestingly, we had a few cases who had lymphadenopathy bilateral, and the biopsy was diagnosed as lymphoma. Though it was not a breast cancer, but it's a interesting finding that we had through the screening projects that these women were coming for a screening and we will find another malignancy also. I will share, this is my last case actually, which was a diagnostic woman from our very first project. As I said, this woman had a lump and she was living in the far periphery. But when she had the chance to do mammogram, she came actually immediately to the van. And it was biopsy and it was lymphoma. She was treated and she's doing well now. So also the idea now, I will talk about the ideas, the challenges which we had with the mobile van mammography. At the very beginning, the issues were like with it was a new idea. You had to tackle the issues of legalization, for example, the van, how it will work on the ward. There were issues with the electricity, the fuel supply, how we'll get it to the van there. So the decision was that we put it next to a Ministry of Health facilities. So next to healthcare centers, where they can have the electrical supply there, the security, the safety, who will make sure that everything is good in the van. So this is the trend. And the other thing was to look for areas which are remote from the AMMAD, or where they don't have mammography unit there in the same region. And the financial coverage. So also all these women were supported by the Jordan Breast Cancer Program to do mammography till biopsy. All the mammograms were performed in the van, they were sent to KHCC. We had issue with the transfer of the images. In two sites, we had the support of the internet by the Cisco company, which they could send the images directly. So we did not have to copy on a CD drive and take it and send it back. But now in the other cities, we are using by copying the images in the CD. So this definitely issues to be considered if you are having a mobile van mammography to send the images digitally. And I think that things are improved now. It depends on the local area network. And we had some issues with sending them through some of this software for transfer. And we had at the very beginning issue with the maintenance. So this was the responsibility of our center, KHCC, to take care of our biomedical engineer, our mechanical engineer also will go to take care of all issues related to the mobile van there. But the general outcome that, as you see from the number, more than 20,000 women done in the past almost 8 years. So the women are willing to do screening mammography. And once they had the idea where to go, they are willing to come for the diagnostic problem. And this is important to consider if you are planning to do any breast imaging services, the acceptance of the woman of the idea. So our initial experience that the women are willing to do mammography, the uptake was more than 70 to 80%. And I will just mention the few last words about how they get the woman to do the screening mammography in the mobile van. There are so-called health educators who will go to the village, for example. They will go to the houses, to the mosques, any place where the women gather, the schools, and they will educate women about the self-exam. And they will tell them that we have a mobile van seated, for example, next to the healthcare center. You can do mammogram there. And they will arrange for appointment and they will do it. And the uptake rate has been increasing over time. And the other thing what we noticed that also are going for so-called second round or third round, women are asking now if you want to go to another city near to us, can we do the mammogram? And they are going to do that. So the van coordinator will arrange for them a second round mammogram. So thank you very much. Thank you very much for everybody. I don't know if you have any question now, or would like us to keep it till the end, or.
يعطيك العافية دكتورة ليلى. Thanks a lot for your nice presentation. It is really a very good experience, and I think we all learn a lot from it. I have one question before going to the before going to the participant questions. How do you encourage people in the suburb area to do screening mammography? I saw already, mashallah, your data, it is very high numbers. So do you think that joining screening program with educational material or lectures is a good idea or not?
Yes, thank you, Doctor. The awareness campaign which were done since 2007, it usually covers the Amman city, the capital, and also the other cities. So they were going outside to the governments, to the suburbs. So you will have this advertisement there. The other thing, as I mentioned that how do we invite women? They will go there, they will educate. The healthcare educators, they are women trained specifically about certain information. They will have with them the booklet, they will have with them models to explain for the woman what is breast cancer, what is self-exam, how they will feel it. And when they talk to the woman, they will advise her what you are going to do, what's the benefit of mammography, and that the mammogram will be read at King Hussein Center. You may have additional exams there. So the uptake of the woman, it was, I think the women now know the issue of breast cancer after these past years of awareness. Because when they come, they will say, like we already know, you have always put advertisement here and there for us to come. So we are coming for the mammography. So definitely, yes, the rural areas or the far areas have to be considered, and the awareness has to include them, and the women are willing to come. Yes.
شكرا دكتورة ليلى. Interesting presentation and very useful to know what's going on in our يعني surrounding countries. يعني if you are kind enough to stay with us, so if somebody wants to ask at the end of the first session any question, يعني حنكون لك من الشاكرين. Thank you دكتورة ليلى. Now it gives me يعني a lot of يعني سعادة وغبطة to introduce my friend and my I don't know، مش عايزة أمدحها كتير دكتورة نجلاء عشان الأذرز ما يغاروا مني. Professor نجلاء عبد الرازق, she is one of the leaders of breast imaging in the Middle East. We are so happy to have her today to introduce the experience of Egypt in breast imaging. Egypt طبعا one of the يعني first countries in the Arab world to start the breast screening program. طبعا دكتورة نجلة غنية عن التعريف. She is an international board member of the American Society of Women Radiologists. She also led the screening program in Egypt, and also she is one of the very famous interventional radiologists in breast intervention, and يعني with all confidence I say, not only in the Arab countries, even outside. She is heading the breast cancer unit in Alpha Scan since 2003. And this center has most, or if not all, the required investigation for breast imaging. دكتورة أو بروفيسورة نجلة تفضلي. We're so happy to have you today.
Thank you, Fatma, for the presentation and the kind introduction. You are so very dear friend to my heart, and I'm very happy to be with you today. I also want to welcome the other women radiologists who are with us in the panel, and would like, and it will be a pleasure if we can meet so soon, inshallah. I will give my experience during the time I led the National Breast Cancer Screening, and this presentation was a publication published in the ACR. It was the result of 7 years of the program, the challenges and the future promises and the results of the patients. Detection of breast cancer, while it is small, provide the best chance for effective treatment for women with the disease. Benefits of early detection include increased survival rate, increased treatment options, and survival rate, and improved quality of life. Currently, there is insufficient knowledge about the causes of breast cancer for primary prevention strategies to reduce the incidence in its population. The problem related to the breast cancer screening in Egypt, first of all, the financial problems of affording treatment, as more than 50% of the population are below the poverty level. Also, 25% of households in Egypt are supposed to be women. The average cost of treating an early detected breast cancer is 10,000 average, 10,000 Egyptian money, in comparison to the metastatic cost of about 150,000 Egyptian pound. Social, due to wrong beliefs and established myths, the diagnosis of breast cancer in Egypt usually lead to divorce or separation, as we all know. 7 to 8 million ladies are between the age of 40 and 70, the target age, and we were aiming to reach all. The goal was to early detection of breast cancer among the Egyptian population, the Egyptian women population, to decrease the mortality rate of the disease and to provide utmost quality of life of the discovered cases, and also to decrease the financial burden of treating breast cancer in its late stages, as mentioned. Okay, how to do better for breast screening, the early detection, genetic counseling and chemo prevention, early diagnosis, state-of-art management, research and publications of the local data, and experience, psychological and social support of the patient. These are the main pillars we are trying to work on. Regarding the early detection, we worked on population above 45 years for the first 5 years, and then we decreased the population, the target population, to the age of 40, since the expected age of breast cancer among our population was average 48 to 51. No personal history of breast cancer should carry the national identification card, otherwise we can accept anyone. During the first 7 years, we examined 130,000 women screened for breast cancer, diabetes, hypertension, obesity. The program consisted of mobile digital units and static units and the Center of Excellency reporting, where reporting takes place. And these are the setup that remains till the moment. We are working with the same strategy, same technology. Few things changed, but we were working with the same strategy. We have 12 mobile units for screening of the remote areas and the unfortunate areas and areas without static units. The data sent through the mobile unit to the Center of Excellency, where the reporting takes place. The mobile units are equipped with mammography, and also they screen for diabetes and hypertension. They measure the blood pressure, and we have simple kits for glucose level screening. The static units are everywhere in the university hospitals, the hospitals related to the Ministry of Health, and most of these are connected to the Center of Excellency. This is the reporting room in the Center of Excellency. We use the ADSL to transfer the images and report the cases. We depend on the double reading, and we follow our structured report. We initiated this structured report once when we started the screening program. We have our website and the call center, of course, and we work with a multidisciplinary team. They visit the Center of Excellency twice per week to check the challenging cases or the cases with problems or workout. It is our logo. I will give some just a rapid review of our results during these 7 years. In addition to the two-view mammography, ladies were screened for diabetes, hypertension, and the incidence of, with the incidence of 200 per thousand and 400 per thousand and 700 per thousand screened ladies for clinical entity consequently. Statistically positive correlation was found between hypertension, obesity, and positive mammography in our study. 18.4 of these patients has positive family history of breast cancer. It was noted that more than 50% of cases were obese, 46.4 were hypertensive, 24 were diabetics, 44 had positive history of intake of contraceptive pills. The mass presentation was encountered in 42% of the mammography positive cases, microcalcification in 15.8%, and mass with microcalcification in 16%, architecture distortion in 17%, and architecture distortion with microcalcification in 7.6%. More than 42% of the positive cases were non-mass presentation that emphasize the role of screening in early detection of breast cancer. In mass detected cases, the size was mainly in the range of 1 to 2 centimeter diameter, 24%, which gives a possibility of conservative breast surgery throughout, throwing the light of the importance of screening in decreasing the incidence of radical mastectomy. Among the treated cases, radical surgery incidence was 70% and only 30% was conserving breast surgery. Unfortunately, 32 of the positive cases refused or escaped from treatment, throwing the light on the importance of public education. In the future plan of the project during the upcoming 5 years, it was exposed to have more mobile vans to reach more people and to increase the awareness about the disease. This is our age distribution of the study, and this is the BI-RADS scoring of the screened cases. You can notice that the BI-RAD 4 incidence is 1.7%, and the BI-RAD 5 0.4% in comparison to 34 BI-RAD 1, 58 BI-RAD 2, the majority. And this is good for screening, I think, matching with the published results of other countries. There is no significant difference regarding the incidence of breast cancer in the age categories above 50, between 50 and 65, and between different age categories starting from 50 to 80. The outcome of cases, we followed the cases, we give the cases diagnosed as BI-RAD 4, 3, and 4 recall to come for ultrasound and biopsy if needed. And the outcome of this is 40% of cases refused to attend. 20% they found it not needed. Conservative surgery was done in 22 cases. Radical surgery was done in 30, and nothing done for benign. Private operation, 15%. They prefer to go to the private sector, and under investigation in 21% of cases. We also followed the response of 4 and 5. We have unreachable cases, refused cases, escaped cases, and this reflects the importance of public education. Operated in Qasr Al-Aini, operated in private sector, stereotactic biopsy, under investigation, neoadjuvant chemotherapy, positive pathology waiting for response. And this is the incidence of mammographic findings, the mass with microcalcification mass alone, who is the commonest presentation, microcalcification alone, parenchymal distortion with microcalcification. Regarding the mass size, the most frequently presented was between 1 and 2 centimeter diameter. And this is not optimum for screening because we need to detect at below 1 centimeter diameter or even the changes before the mass. But also this reflects the problem in the Middle East or in Egypt specifically about the illiteracy, and they are afraid to come. أيوة. Regarding the pathology, this is a distribution of different pathology. To sum out our results, the incidence of breast cancer among the screened cases was 2.1%. The recall rate was 12%. The mean tumor size was 2.4%. And this is relatively large for screening. The interventional procedure done in 9%. Primary screening in 85%, and prevalent screening was 15%. The overall participation in the screening in the most educated community in Egypt, unfortunately, it's only 30%. These are examples, a few examples of cases. You can see here area of architecture distortion and asymmetric density and architecture distortion with indeterminate cluster of microcalcification. Biopsy was done and the histopathology was invasive duct carcinoma. We have very good quality mammogram, tomosynthesis, automated breast ultrasound, MRI, highly equipped. But unfortunately, the presentation of women in the screening is 30%. This is an ill-defined right retroareolar mass, and the pathology was intracystic papillary carcinoma. Here is a very far posterior aspect, small outline speculated upper inner quadrant mass, and it was pathologically proven infiltrative duct carcinoma, none otherwise specified. Another bigger mass, 4 centimeter. Can you imagine? This was discovered by screening. 4 centimeter diameter mass in the left upper outer quadrant. Here is microcalcification, sector of microcalcification, pleomorphic fine microcalcification, and was diagnosed as invasive duct carcinoma, DCIS with invasive component. Here is a BI-RADS4 scattered and clustered microcalcification biopsied by vacuum and was not proved to have any DCIS. Here is another upper outer quadrant asymmetric density, but seen in the tube views in different appearance, but was pathologically proven as invasive duct carcinoma. Here is another example, small upper outer speculated mass, 11 millimeter, proved to be infiltrating duct carcinoma. Cancer of the breast in women is a major health burden worldwide. It is the most common cause of cancer among women and is responsible about over 1 million death rate and 10 million neoplasms diagnosed worldwide each year in both sexes. It is the primary cause of cancer deaths among women globally. The international comparison of the disease rate by area and time of diagnosis provide important clue to underlying cause of the disease and the effect of natural and planned intervention, and serve as indicator for the scope of preventive strategies. There is at least 10-fold variation in breast cancer incidence rate worldwide, largely as a consequence of range of socio-economic correlated difference in population prevalence of several reproductive, hormonal, nutritional factor, and high resource countries, low resource countries. Mammographic screening has considerably affected breast cancer diagnosis, registration, and mortality. Breast cancer has become a priority health area in Egypt because according to the National Cancer Institute, it is the commonest encountered cancer, representing 38% according to Egypt mortality statistics in 2001. It is the commonest cause of death among women, representing 21%. And according to the Women National Council, breast cancer represents 33% of female cancer and 10% of metastatic at presentation, and average size of presentation 5 centimeters, and average age of presentation 10 years younger than in the West countries. Egypt's total population, the women represent almost 50% of total population, at least 6 million women at the age of 40. Our aim is to screen on not only breast cancer, but hypertension, diabetes, and obesity. And there is chosen for the healthcare, the Women Health Outreach Program, or Egypt breast screening program. There is a limited number of radiologists, which is challenges. The challenges for the program, the large number of patients that we aiming to screen. Second, the limited number of experienced radiologists or specialized in breast care. The Women Health Outreach Program affords solution for these two main problems. The problem uses the mobile van to reach more women, and we arranged education and workshops and educative panels and formulas for teaching more radiologists. We have very good care about the teaching programs of the young and training through many organizations. The challenges and future plan of the project, the main challenges were the operator error as well, the patient illiteracy, the increased demand to maintain the continuous funding for purchasing mobile units and maintaining annual running cost. The introduction of screening of breast cancer in Egypt will continue to provide role of primary prevention, early diagnosis and treatment, raising public awareness about the disease, and role of screening in the primary prevention will continue to be the main weapon to fight breast cancer. So to do better, we need to work on the financial problem, incorporation of the NGOs for population awareness and education, advocacy group, media campaigning to decrease the myths about the breast cancer, work on achieving quality manual and quality assurance program, breast radiologist training and education, collaboration with healthcare providers for breast cancer screening treatment to help patients all through the journey since they discovered till the final treatment. Collaboration of the breast cancer screening in the Middle East with others, with our colleagues and our friends in different countries in the Middle East. Research, studies, and trial on our special problem like breast cancer in young and inflammatory breast cancer. Vertical diversification excellence unit for screening of young and hereditary cancer, including MRI, automated breast ultrasound, and assessment of BRCA genes. Horizontal diversification and merging screening with of cervical cancer and other women health issues related like osteoporosis and nutrition in cancer. And thank you for your time and your concern, and thank you for the kind invitation, and thank you, my dear lovely friend Fatma, for bringing me to this panel today. Thank you.
Shukran, Professor Najla, for this beautiful comprehensive presentation. I think you made it so clear that breast cancer battle in the Arab world is not easy. However, I would like you please to stay with us to the end of the first session at least, because a lot of people raising their hands, there is a lot of questions. So please, can you join Dr. Layla for waiting for the end of the session so we can answer the questions for the attendees. شكرا كتير, we'll move to our next speaker.
Our next speaker is His Excellency Dr. Khalid Al-Thani. He's a founder and chairman of Qatar Cancer Society since 1997. He has also served as chairman of the Gulf Union Against Cancer since 2000. In addition to his work with the Qatar Cancer Society and the Gulf Union Against Cancer, Dr. Khalid also served as Vice Chairman of the National Health Authority, which is replaced by Ministry of Public Health in Qatar. He is a King Faisal University graduate. So welcome, Dr. Khalid Al-Thani.
Well, أول شيء السلام عليكم وشكرا جزيلا على هالintroduction. I wish, and you just mentioned King Faisal, and I'm proud, and I went to King Faisal University. دكتورة فاطمة أختي يعني it's been a long time since I have seen you, لكن ولي الشرف إني أتعرف على الأخوة البقيين، وإن شاء الله لي زيارة قريبة جدا لكم.
نورنا.
الله يبارك فيك. أنا if you don't mind I will upload the presentation. I have معي الدكتور هادي أبو رشيد who's our head of research and head of development of program, because we have a huge training center here where we do the CPD, the continuous professional development for nurses and physicians in Qatar, and they are all trained here. So it's his work, and we both share the work, but let him start on the slides and then we'll follow up, if you don't mind.
Assalamu alaikum. Thank you so much for having me today, and thank you, Your Excellency, Dr. Khalid. It's actually an honor to learn from you and work with you, and learn from your passion and actually motivation for in the work and philanthropy in the area of cancer. So I'm gonna just directly jump in. So here I'm gonna start with the breast cancer burden according to the Global Can IR 2020, the estimation. As you guys see, it's clearly. And this is not only in Qatar, actually worldwide, breast cancer is number one in the estimation number of new cases and incidence in both, if we look at both genders and all ages, estimation of 15%. This according to IARC. If we look here, according to Ministry of Public Health, projection of a number of new cases of incidence of breast cancer till 2035, as it's steady. There is a steady rise in the number. Looking at the 2035, around 700 women will be newly diagnosed breast cancer. If we look at, we always like, and we learn from His Excellency when we put numbers, put it in international perspective, how we actually comparing oranges to oranges. So age standardized incidence rate for breast cancer in state Qatar, according to Qatar National Cancer Registry 2018. So 94 women per 100,000. That's for incidence, and that will tell us actually how much focusing on the screening, early detection, and the age standardized rate, if we look at the worldwide, is comparable to the European Union. And the mortality, age standardized mortality rate is 6 per 100,000. And that's actually, will say that we are proud of collaboration of all health stakeholders and community, and also the NGO and civil society, as mentioned by Dr. Najla, representing Qatar Cancer Society, in collaboration in getting early detection, and which is play a role in reducing mortality. If we look also on the age group, the age group that with the highest incidence of breast cancer 2018 among female is 45 and 49, and this is not something we're all aware of in the GCC area, that breast cancer is actually start in a younger age compared with the Northern American, Western European. Here, it's kind of give you a kind of spectrum how the Qatar National Health, Qatar National Strategy moved to the to implement. Based on that, we implemented the Qatar National Cancer Strategy in 2011, and that pushed toward establishing National Cancer Program and a Primary Health Corporation, and they are the one that actually doing all the hard work in the breast and bowel screening program, and but with the collaboration, all the entities in the National Cancer Program to promote and push the effectiveness and outcome of the breast cancer screening program. If we look what are the centers that we have so far, and I say so far because there are 2 in the pipeline, there are 3 breast cancer screening suites. They are more like spa-like suites, apologize. actually they provide the breast cancer screening service. And also, in addition to that, we understand the importance of the mobile mammogram. And it's actually, this service is not for, the health centers cover all the needs, but the mobile mammogram is more putting more emphasis on the people see it in the roads, see it everywhere, see it close to their house. So it's more a tool of awareness.
If I may interject in this slide, actually, we've been using the mobile unit as a mode of social recognition. So we've been using a lot of the wealthy and well-off people, mainly ladies, society ladies, to invite a group of their friends, get the mammogram mobile unit into their homes, and let them have the upper hand in encouraging people. So this is a program that is doing very well. At the same time, we utilize them to donate to Qatar Cancer Society. So the Ministry of Health does the work and we get the money. Just a small.
And this actually will build on the importance of stakeholders collaboration. And here in Qatar, we are all sitting on one table, and that's actually where all the coming from the leadership of the investing of all the stakeholders to be involved in a better outcome for women health. And that's what we emphasize, one of the emphasis in our leadership here. So if you look at the guideline eligibility criteria, according to Ministry of Public Health, the screening guideline is a mammography and should be done every 3 years, starting age 45 to 69 for all women that they have valid Qatar ID here, for citizen and resident in Qatar, that they have no symptoms of breast cancer, and they have not done it in the past 3 years. Just kind of touch base quickly on the pathway. It's the woman could access the service through self-requesting, through physician referral to invitation. Actually, they will be called through the call center, and all this data get to the Primary Health Corporation through the Ministry of Interior. So we have all the data, and that's what's unique. We have one identifier number that connect all health record and everything connected through the Qatar ID. And that's one of the unique advanced system in electronic medical record in the state of Qatar. And the call center will book an appointment. They will come into the check-in center. And here, the setup, I want to elaborate more. It's placed on a way that actually it 100% private, the privacy, the comfort that the woman, we tried, the journey of the woman will be really quick in a comfortable, private way. Then after that, they go to risk assessment. They get risk assessment, or they're giving score for that. Also for the future will be in the record. Mammography, and the mammography, they get 4 images and double-blind reading, so for the accuracy. And in the future, we are working on having the second reader to be artificial intelligence. And that's where the innovation is moving forward in the breast cancer screening in the state of Qatar. The result, if it's abnormal, they will be called back to the health center. They will be meeting cancer champion. So the cancer champion is a healthcare professional that they've been trained, and part of the training we collaborate with the PRCC as Qatar Cancer Society to train them how to deliver breaking bad news and possible concern. So they have the best communication skills in delivering such a difficult news sometimes. And they go to Hamad Medical Corporation. They have a breast care center. They have the triple assessment done there. And if it's positive, they will move forward within 21 days from the moment of diagnosis till the day of treatment. And diagnosis usually based on histopathology. But that's actually one of the KPI that very strictly monitored, so for the patient to start treatment as soon as possible. And I know His Excellency always kind of admire this actually, that we are living up in the healthcare system in the state of Qatar to maintain these goals. Here kind of touch base on the compare the screening performance parameters in Qatar with international standards. So screening coverage by invitation. So invitation to eligibility, we have 97%. The ratio of screened to eligible, or screening coverage by eligibility, 51%. We are here closer to the Australian and higher than Canadian standard. And if we look in the screening participation uptake rate, it's actually, according to the strategy, it's 30%, but the program is achieving more, 52%. So that's by itself, see that And the abnormal screening, or recall abnormal mammography, it's in the international standards, actually above the 13%. And if we look at the positive predictive value, it is within the range of actually a higher rate with 5.8%. So that's kind of put everything in perspective. And cancer detection rate, if we look at the overall cancer detection rate, is 7.8, and it's same UK standard and closer to the American Canadian. If we look at ductal carcinoma in situ, same detection rate almost, and intraductal carcinoma, invasive ductal carcinoma also, we are talking about the same level. Program sensitivity is up there with the Australian standard. And here, that's important indicators, breast cancer screening, interval cancers. If we look at the 0 to 12 month first year, second year, and the third year, we are following close to the international standard. And here, what I want also to emphasize, and I know His Excellency has a passion about this, the community awareness, we agreed, and actually with the motivation and advocacy from Qatar Cancer Society and His Excellency, to agree on a nationwide cancer awareness calendar, that we are all talking the same language, same messages, same awareness activity. And every month is different, and all the entities talking the same. And October is, as we are aware, we all work on breast cancer from all entities, from private, from government, from academic, and this is a topic dear to my heart, is actually training the healthcare professional, and it's not because just this is something I like, because this is actually based on the feedback from here, from the strategy and situation analysis, that the investment should be in the primary and community care. Also, even at international level, the latest report from the Lancet Oncology, that primary care is taking more and more role actually in breast cancer care, and the investment should be there. And that's what we are focusing in, dividing CME in our training center, CME, and now they call it CPD. It used to be CNE, they're always changing, but it's the concept of continuing medical education in our training center. And here we are fortunate to have established unique training center, and one of the kind in the region, in collaboration with social responsibility from Ooredoo Telecommunication Company. They were supporting in establishing this center that has capacity of more than 300 people in the same time. And this here, the picture here is actually picture one of our recent breast cancer conference that had more than 3,000 people attended this conference, a variety of sessions and topics. So, and actually one of these activities is such an important, and I don't know if Dr. Khalid want to, your experience in reflection on breast cancer conference. And regarding a lot of people, I'm sure they're going to ask, and I see there is another talk about breast cancer screening and COVID. So the breast cancer screening in Qatar has been suspended as of the 11th of March 2020 after with the precaution measures. And inshallah, it will restart either in November and December. And here, this actually has been publication, and there's a lot of thinking process on how we could actually, what's the best schedule to catch up on the, are we going to start with the people that already had the screening before and follow up with them, or are we going to pick the new one? It depends. That's all based on the feasibility studies. And thank you so much. And please, this is our social media, and please scan this barcode. It will take you directly to our app to stay in touch with our program. Thank you.
Thank you, Dr. Hadi. If I may just add a few things. The reason I had Dr. Hadi sit with me for two reasons. Reason number one, كنت في الوزارة من الصباح عندي 60 اجتماع فجيت مصدع. I'm afraid, يعني knowing Dr. Fatma and the team, I know that we'll be bombarded by some questions. So I needed somebody professional. And number two, it's his work because he is the link between the Qatar Cancer Society and the cancer program and the Ministry of Health. My role actually plays at the higher role of pushing people around and trying to make sure that they adhere to the programs and deliver the programs. We are blessed in Qatar for many reasons. Reason number one is the geographic size of the country is not that big. So we only have one reporting center and one facility that looks at all these cases. Yes, all registry or all people come in through the primary care because the system has pushed people into the primary care for anything that they would like to do. we would like to see the program restart again. During COVID, they were only seeing people with certain complaints that have been examined at primary care centers, and if they suspect anything, then they are taken in. We have reached a stage where from the time the patient calls until they are seen is a maximum 48 hours. So that's a number that we were proud of. And I think now after COVID, they have to recover and deliver go back to the same timing, because COVID have disrupted a lot of things. Other than that, we have certain agreements with the Ministry of Public Health that we cover all education, we cover all publication, we cover all community-based education on cancer, and whether it's breast cancer or all sorts of cancers. The Qatar Cancer Society is doing it, and they do the service, and we have a synergy. I hope we didn't take much long time, and I'm open for questions or later on.
Perfect, دكتور خالد as usual and دكتور هادي. تشرفنا بوجودك اليوم دكتور خالد، وأنا سعيدة إني شفتك. يعني كان آخر مرة لنا هي يعني يمكن 4 or 5 years ago، بس الحمد لله إن شاء الله نشوفك قريبا في السعودية.
قريبا إن شاء الله بكون في الشرقية
وفي الشرقية وفي بيتك جامعة فيصل، جامعة الدمام، جامعة الإمام.
والله أنا ما أقدر أقول إلا جامعة الملك، دائما أقول جامعة الملك فيصل، والكل يصحح لي من الإخوان والشباب.
أنا وأنت فيصل، كلنا فيصل. وبعدين الله يسعدك. شكرا جزيلا دكتور خالد. يعني احنا نطمع كثيرا في الكرام، ف if you kindly stay with us for the coming 20 minutes نسمع البرزنتيشن حق الدكتورة نور، then we'll start the question. أنا شايفة الإيدين المرفوعة قاعدة تزيد، وأنا نفسي برضو عندي سؤالين على المحاضرة. شاكرة مقدرة، we'll be back after the next speaker.
Our next speaker is Dr. Nora Naimi. She's a breast and women imaging consultant. She's a leader of the National Screening Program in Eastern Province and director of Mayil Jabr Center for Early Detection. She's a chairperson of Radiology Department in King Fahd Specialist Hospital in Dammam. Dr. Noor will speak about a National Screening Program in Saudi Arabia. Welcome, Dr. Noor, and you have the floor.
Thank you very much. Thank you, Prof. Fatma, for the invitation and for the wonderful organizing team. My presentation will not talk or tackle the National Screening Program as a whole. I will try to talk about or give a deep dive about the Eastern Health Cluster Screening Pathway, which is an evolution of the National Screening Program within the Eastern Province. So our objectives here is to go through the national and international statistics and compare our status with the international statistics. We evaluate our current status and do some analysis, going through the rationale of choosing the breast cancer as one of the main pathway or programs under the Eastern Health Cluster to be recognized for budget, for resources. I'll talk about our protocol in assessing the average and high-risk screening ladies, then development of breast cancer early detection pathway. As far as today, we don't have a recent national cancer registry data. The latest was in 2016, which is not very much different than the one we are using now or referring to, which is from the WHO under the Global Cancer Observatory. If we just focus on, let's have a wide scope analysis or data from the WHO and observatory. It shows that the cancer of breast among females worldwide is still by far is the most prevalent cancer, almost 3 times the next, which is the colorectal. If we deep dive in Saudi Arabia, we can see the breast is again the same as the highest, followed by thyroid among females at any age given. Now, as per the reference last year, which is 2020, we have 13,632 ladies tend to have cancer. Almost 30% of them were breast. So now we know, which is referring to the literature and the studies and all the proofs data, that detection of DCIS, which is the ductal carcinoma in situ, exhibit a relative survival of affected women of more than 94%. For invasive breast cancer of less than 1 centimeter, relative survival after 15 years ranges from 90 to 92%. For tumors of 1 to 2 centimeter, it ranges around 75% and continues to drop with the increase in tumor stage. On average, the death rate increased by 1.5% per millimeter increase in size. Breast cancer is not preventable disease. However, it is curable if detected at early stage. So all above numbers and data reflect that there is a direct relation between the size of the tumor at the first time or the detection and the rate of survival. So we know now it's not curable, it's not avoidable, but it can be controlled by early detection or screening strategy. Now, I'll just share with you some of the rationale that we wanted to convince our higher authority under the Eastern Health Cluster that breast cancer screening is one of the major issues and one of the big problems going on. We might not be able to see, to detect, but obviously we, at the level of the tertiary service provided, receive the late presentation of the disease. So as per the statistics that we have, the breast cancer account for almost 16% from all cancers reported among Saudi nationals, and to almost 29% from all cancer reported among females at all ages. If we just go in more focus approach, we see that the Eastern Province is the highest, and the number of detected cases is 36.2 per 100,000. So the cost of treatment, and if we consider even the financial aspect of the disease, there is a huge cost of treatment, let alone the life loss. So breast cancer is not preventable, but controllable by early detection. And the only way approved of early detection is a screening mammogram. Secondly, we wanted to define yes, we know that, we hear that it is everywhere, everybody is running a screening mammogram, but we wanted to make it in a more scientific, formal way. So we agreed on something and we put guidelines to start with the project itself. So we defined the screening that it's utilizing a radiology tool to detect the disease at early stage before the appearance of symptoms, by which there will be less invasive treatment options and survival rate will be higher and overall better outcome. Now, this is part of the exercise we have done to know the population, or let's call it how huge is the problem we are dealing with. We know that in Eastern Province, under the Eastern Health Cluster, which is the EHC, there are 242,324 ladies are among the targeted group, which is all aligned with the national screening program between 40 and 70 years old. There are other things that we want to consider are the availability of resources. So we try to adapt a strategy considering the resources that we will not screen the ladies, the whole number on annual basis, so every other year. So we divided the target into half. So our target this year, or our initial phase 1 target, is 121,162. And we adapt a cascade of increasing the number per year. So last year target was 7,000, which was achieved. Next year, this year should be, we added the number we do by the end of the year, and it should accumulate to 14,539 screened lady. This is a screenshot from the National Screening Program. We wanted to do a deep analysis on what we missed before, what is missing, what are the area for improvement, and how can we tackle it What is the strategy? So we know we don't want to go back. We want to do more focused, more process improvement. It seems that we don't have a really integrated care. We have a weak referral process from the primary health centers to the screening centers, lack of care coordinator. So there is no way to follow or to track patient after referring them or discovering that they have a suspicious lesion. No clear identification of early detection clinic in the region. Reading center and protocol are not mature as expected. This is the pathway which was adapted by everybody in the Eastern Province. As you can see, there is no clear way where to go. So the patient or the lady, if she was discovered, she has to go back to the primary health center. Then the primary health center will refer her back to the hospital. Then from there, nobody knows what will happen. If she got her appointment, if she's turned positive, if she received the treatment within a reasonable time frame or standardized measures, there was no way to track the lady within the referral system. This is again another pathway which was placed initially. It tackled the mobilization of the mobile unit and the traveling of the unit among the allocated centers. However, again, it does not tackle the flow and where the lady will land at the end of the pathway. This is a little bit busy slide, like inshallah, it shows that the way we revise things, we know that we have a strengthening point. We know that we have a weakness areas and we wanted to improve them. So we know that the awareness program, kingdom-wise, was one of the mature things that have been done. So every year we have a good awareness campaigns, and it was one of the major events at the health-wise happening was the awareness campaign for the breast. Now we wanted to strengthen the role of the secondary care to excel the diagnostic service. We know that we are lacking case coordinators to facilitate the journey of the patient between different layers of care provider. And we know that the access to the tertiary service is not as expected. Now, if we have a deep dive regarding the screening and awareness, we know that women are avoiding mammogram partially because of the culture, partially because of the myth, as my senior colleagues mentioned before. Sometimes it's difficult to access the machines themselves. Sometimes there is no unique screening measures. Some of the primary health centers are more active than others. Others, they never refer ladies unless they complain of something. So it's beyond now the screening status. We ended up by having two major issues in our adapted program, which is the entry point for the ladies and once the lady is entered, which is one of the challenges, she's lost inside that, and there is inside the pathway, and there is no solid referring system among level of cares. Part of the exercise we needed to do is the reviewing our resources. So as Dr. Tahoun mentioned, that we needed to know how many of, you cannot start program without ending it. One of the major rules or first rule in medicine is do no harm. Some ladies, we invited them, then we discovered the cancer, then we don't want to send them home without telling them or taking care of them till they are transferred from closing the loop or transferring from being diseased to cured ladies. So we wanted to know the available resources under the Eastern Health Cluster. There are one mammogram machine at the Medical Complex, one at Al Jubail, one at the Maternity Hospital, and one at the Charity Mail Jabbar Center. So in total, there are 4. We have 2 at King Fahd Specialist Hospital, but this is a different layer of service provider, so they were not counted. We have 82 PHCs, primary health centers, and they are distributed among Dammam, Khobar, Qatif, and Jubail under the Eastern Health Cluster. Now, part of the program assessment is to look into the guidelines for screening, and which is part of which is the risk assessment models that we use. We adapted in alignments to the National Screening Program, the Gale Model, which is basically assessing the chance or the risk of having breast cancer lifelong. Basically, it's 3 components, part of which is demographic data, patient eligibility, and patient family history, after which the result will show in 5 years risk of developing breast cancer and lifetime risk of developing breast cancer. We categorize ladies according to the risk assessment module into average risk and above average risk, which are the intermediate risk and high risk. So when the lady is less than 50%, she's having less than 50% lifetime risk to have a breast cancer, so she's average, which is the general assumption. So our assumption is that most of female population 40 years and above are average risk. Whatever is above the average risk is considered in the program, but they are not the majority. We adapted the American Cancer Society and American College of Radiology guidelines, and as well the NCC guidelines. The primary modality for screening used is the 2D screening mammogram. However, 3D, when it is available, is acceptable. Our targeted group was 30 years old and above. Mammogram is a low radiation dose. Modality, it can detect small calcification. It's fast procedure and relatively cheap. Yeah, the exam itself should not take more than 7 minutes from getting in the room and getting out, maximum 15 minutes. 4 views are obtained and sent. One of the challenges for 2D mammogram is the breast density, which is something we're still exploring because of the age of the screening program in Saudi. So whenever it is more dense, the 2D mammogram is less sensitive. That is the time we resort to the 3D to reduce overlap shadows. Detection of small lesion is feasible, and other sign of breast cancer like the asymmetry or distortion in the alignment. It supersedes 2D dense breast, and there are synthetic images that can be produced, so the radiation exposure is controlled. It's as well acceptable by ACS, which is the American Cancer Society, as both with the 2D as one of the mammogram screening tools. We looked into the modality selection or appropriateness in relation to the age as well. So we consider the radiation and the age-related tool utilization and the lifetime risk. So by all measures and by all means, when they are average risk, 40 years and above, the first modality to go is either 2D or 3D. High risk category, there are subgroup that are considered in the development of the pathway, but they are not the majority because we assume from the beginning that most of the ladies are average risk female targets. Ultrasound made sure or clear that it is not one of the screening tools. It's a complementary because of the all obvious scientific reasons. Now, after that, we developed together, and it's a committee made of different members, a part of which was the radiology. We have oncologists, we have breast surgeon, we have public health, we have project managers, we have IT as well, all the supportive team and the main resources were included in developing this pathway. Again, it's a busy slide. However, it just tracked the lady throughout her journey. We started by the catchment pool to the right, to the left side of the screen. We can see that most of our targeted group are coming through the primary health centers. So this is one of the areas for improvement we tackled from the beginning. The other source, which is less likely to be utilized or at least seasonal, which is the campaigns, schools and malls. Once the lady is in at the primary health center, risk assessment is made for her and she's categorized according to the calculated risk results. Again, it's an assumption, which we will still explore, that most of our ladies are average risk group. After that, she will be referred to one of the areas where the mammogram is allocated. Right now, most of the screening is done at one center. When I'm still talking about the Eastern Health Cluster, is at Mail Jabbar Center. The ladies will be scanned, then a report investigations will be done. And if they turn positive, another coordinator will be in charge to refer them directly to the tertiary service provider. If they are 0 or 3, they will still within the, let's call it expanded or extended screening center at Mail Jabbar, and they will be managed there. 3, that's if like, for example, if they are having a benign, probably benign nodules, and they want to do surgical procedure, they don't want to follow it up, then they are offered this as well. They are granted this. This is a deep dive for the high risk group. We, according to the clinical and risk assessment we are doing. So if they, according to the, I have a little bit technical problem. Yes. So if we have they were labeled above the average, then they should follow a different pathway. Currently, we are not resourced to do this. One of the recommendations, as per the guidelines, is to do mammogram, genetic testing, mammogram alternating with MRI. Right now, it's not feasible. We invite them during the diagnostic session we are doing at Mail Jabbar, just to explore, let's say, explore the pattern of disease among our community. Of course, we wanted to know how far, how good or how bad we are doing with our program. We placed some of the KPIs to control the lady's journey from the entering point till the exit point. I'll just go through some of it. For instance, a percentage of average risk ladies who were referred from PHCs. The expected is on monthly basis that more than 60% of the ladies who visited the primary health center, and they are falling within the age group that are eligible for screening, should be referred to the screening centers. Part of our KPIs is percentage of attending patient classified by RAD3 only, by RAD5, sorry, only, which is the highly suggestive cancer, who performed biopsy within 3 weeks from screening result. The expected percentage is more than 90%. Again, one of the major and important KPIs is the percentage of positive cases for breast cancer through biopsy were detected within 4 to 5 weeks from screening mammogram. It is still under development, by the way, the KPI, and still not approved because it has to be approved by different stakeholders. One of the important as well KPIs is the percentage of patients with positive cancer accepted for treatment within 6 to 8 weeks from screening mammogram. The accepted percentage or the aimed percentage is 90%. Right. Challenges. We have two main challenges: limited resources, I'll just start with it, and then compliance. The limited resources, which is the thing I mentioned, limited regarding the manpower, number of technologists, number of reading radiologists, number of PACS or IT support for reading, number of machines, mammogram machines. The compliance, which was partially surprising to us, that the compliance from the referring physicians themselves, it was part of the challenges we faced, that the physician at the primary health centers, they were not as accepting or recepting the concept itself of referring ladies when they are within their clinic. So when the lady is following up for diabetes or blood pressure, it was, as per the primary health center physician, it should not be expected from them to refer the lady to screening while she's not complaining of something. It took us a while to put them into, or to turn them into this mood and or this level of responsibility, and to get engaged as part of the influencing team and changing patient's life. Again, this is just a slide to show you that we during our starting point, we missed one of the machines, which is the one in Qatif, one of the very important areas crowded with our targeted group. So we were started with limited resources. This slide, it shows the, I will call it, it just reflects how we behave, or we, our staff, our healthcare provider under the Eastern Health Cluster, how they behave, and it changed seasonal. For instance, this is for 2021, number of referred cases per month. You can see that April and May, it was before Ramadan and during Ramadan. It's almost in the lowest throughout the year. Then, as if they were like feeling guilty, maybe it was recovered high, then it went back. And that's it. So it's ups and downs, and it's one of the important area of improvement. Without it, you cannot succeed any program without the referral. Very quickly, an accomplishment which is shared with everybody. This is, I'm just comparing a number of mammogram done on Mail Jabr as one center of the. One of the centers, one of the main centers. And if you just focus on the pink color, it reflects the number in comparison to the gray, in comparison to the orange or the blue. So every year we are tackling our, by the way, we started almost 2020 with this deep diving into the national screening program. So every year we see that we are almost doubling the number we have done before. And accordingly, we discovered more cancer cases. So as per the recent, including October, we are now almost, I think, 38 detected cancer throughout this year only. Thank you.
شكرا دكتورة نور, يعطيك العافية. It's so good to hear the follow-up of the screening program in the Eastern Province. Now I would like to ask everybody, if they have question, please to write it. And until we get question, I will start. I have few questions. دكتورة ليلى, دكتورة نجلاء, دكتور خالد, دكتورة نور. First question, I think from what we heard, the four presentation, everybody was talking about opportunistic screening. Is there an organizing screening program in the four countries for the presenters? تفضلوا دكتورة ليلى.
شكرا دكتورة فاطمة. Thank you, very nice talk من الزملاء جميعا يعني والأطباء كلهم. In Jordan, no, we don't have organized screening program. There are efforts, as I said, by the Jordan Breast Cancer Program بهدف التوعية، وفعلا صار في إقبال من السيدات نفسهم، وفي زي ما حكينا جهود متفرقة كلياتها. يمكن المثال الواحد أنا حبيت أستخدمه موضوع الشاحنات المتنقلة، هذول حالات فعلا سكرينينج، فبعطي فكرة لو كان فعلا في عندنا معمم برنامج شو حيكون الإقبال وشو حيكون الريت.
السؤال الثاني دكتورة ليلى, how many ladies they come back for second or third screening؟ هم نفس الأسئلة حسألهم على الفور countries.
هلا exact number ما عندي، بس من مشاريع، من تجربتنا بالمشاريع نفسها بالموبايل فانز، إنه كان بس تنتقل من مدينة لمدينة. those who will come ممكن أحكي تقريبا 20% to بيختلف المنطقة 20 to 30% يحبوا هم ابن حالهم يجوا للسكند راوند، يعني هم يتصلوا يحبوا يسألوا إنه بدي أجي مرة ثانية.
شكرا دكتورة نجلاء. الدكتورة نجلاء ما سمعتنا. دكتور خالد, do you have organized or opportunistic screening program, and how many ladies they come back for second mammography?
Well, we have a total, it's a very well organized population-based program. So what they do is they look at the age-wise, and because, you know, they share the complete data from the Ministry of Interior. So what they do is they call them directly, they call ladies, they send them text messages, they ask them to come in for a selective or an elective sort of screening program. And they do register a lot of ladies. People or ladies above 50, they call them many times to make sure that they come in. And that's it's very well organized. Now, we don't have the actual percentage for the secondary examination, because this program started 1 year before COVID, and during COVID, everything slowed down. So hopefully by this month, the relaunch of the program again, but it is a population-based, and everybody is asked to come in for a mammogram.
Dr. Noor, is it organized or opportunistic?
Unfortunately, although we appreciate all the effort put in this for years, almost we exceed 10 years, started from different countries, and at regional initiation, you were one of the leaders, Dr. Fatma. Unfortunately, no, but I think population-wise, we are more aware and alert. Like everybody now is working on at the level of the Eastern Health Cluster to link it to Tawakkalna, or to link it to one of the lean program, which is the National Medical Record. So maybe by this we can tackle the targeted group and make it more organized rather than, Wallahi, it's not happening. Like it's an active process. We are attending meetings to put this on reality, inshallah. Annual. We adapt the annual, we call them. We started 2020 almost. During this year, we have the glitches of having Corona or COVID, where we closed the center for a while. Then whatever, the number we are getting in 2021, we appreciate, and we'll start the comparison with the next year, inshallah.
دكتور نجلاء, عندك أي تعليق؟ طيب أنا ليش سألت هالسؤال؟ لأنه unfortunately دولنا العربية we are putting now يعني a good amount of money. However, having opportunistic screening program will not give you the real either incidence or what's going on. So even as Fatma, I thought because the kingdom is a very huge country, even I was proposing to do the screening program, organized screening program in the hot areas. Like for the last, since the cancer registry program started, it always المنطقة الشرقية والنeighbors حقتها المنطقة الخليج, we are the highest incidence of breast cancer in the Gulf. So I was proposing to have at least organized program in the hot areas so we know what's going on. Because the way we are doing it as opportunistic screening, everybody knows it will not give you a real facts. النقطة الثانية اللي أنا I would like to and I think it was clear in the four presenters, what is the relation between the primary care or the people who should transfer patients for screening with the screening program? Because it is clearly that they need to be educated, and educating the educators are a big demand. Until now, it's clear that the primary care are not doing their job properly because the referrer is not as expected. The other thing we proposed from our experience, like في الخليج الدول شوية المتحفظة, إنه most of our people, they don't go to primary care. They don't have their own doctor who's following them. So we proposed to educate the OB-GYN doctors, because most of the ladies, they go to OB-GYN. So we did that. But unfortunately, I believe that without heavy involvement of the primary care doctors, I think our screening programs just يعني ما أقول lots of efforts, lots of money will be put on, but not the expected result. أشوف دكتور خالد, you like to comment? شايفتك رافع يدك.
Yes, دكتورة, طبعا what you are saying is absolutely right, but it's unfair for me to present in the presence of Kingdom of Saudi Arabia, Egypt and Jordan, because of the huge number of people, huge and vast geographic area, which definitely I don't envy anybody who's in control of the health services in the three respective countries. Doesn't matter. It's not the matter of money. We are blessed because of the geographic and because of the proximity of the towns and cities. And we are blessed because the decision was taken at one point. Primary care, you have to go through primary care. That means you have to go through primary care. So there is no red tapes. I cannot call anybody and cut short anything. So they call them, they keep repeating calling them, and they repeat calling them, and then it gets to a point where everybody starts to adhere. So, which is easy to handle in a small population, very easy to handle. It's not easy to handle in a large population. It doesn't mean that you don't need to or you need to stop. No, you need to do a lot of work at the higher level, so it comes across the pyramid in a much easier way. Otherwise, you're going an up battle, which is very difficult.
You are absolutely right, Dr. Khalid. Lakin I think a screening program, if it is not organized, the harm of losing a lot of حيكون فيها financial strains to the country, which is, it should be counted. We have to start, at least as I mentioned, in all areas that we think the incidence is high, we have to tailor the screening programs according to the incidence. And this is not only for breast cancer, but also for other cancers. دكتورة ليلى تحبي تكمنت؟ دكتورة نور، دكتورة نجلاء؟
نعم. أنا موضوع البرايمري هيلث كير this is really an issue. إنه as you know by the ACR recommendation you can accept self-referred patient for screening mammography, وهذا اللي يمكن الكل عم يعمله إلا لما يكون في عندك primary health care center. But definitely you have to have at the same time a primary health care, so you inform the result for the patient and her primary health care. فريلي we face this issue احنا in Jordan إنه مش كل المرضى عندهم primary health care physician. صح ما دكتور خالد إنه this is an issue. يعني once is a system of primary health care established, هذا definitely it will enhance موضوع السكرينينج because you can accept the patient any center or refer her back to her primary healthcare physician بغض بعض الاشياء اللي حكتها الدكتوره نور انه في صعوبات فيها. الموضوع الثاني برضه I noticed with Dr. Najla cases that she had really advanced cancers like mass stage 2 maybe or 3 by the mammographic size على screening. This is كمان raises an issue on موضوع الكلينيكال بيست اكزام واهميته. We should not ignore موضوع الكلينيكال بيست اكزام. I am a radiologist, I am with the screening. بس really الكلينيكال بيست اكزام whether done by the primary healthcare physician, the GP, family medicine أو الطبيب النسائية حتى. This definitely has a role because we had encountered a few cases لو كانت المريضة محسوس الماس عندها مفحوصة كان ممكن حسب أبكر ما تيجي حتى على السكرينينج ماموجرام. وديفنتلي educating البرايمري هيلث كير فيزيشنز مش بس يعني زي ما حكيت الأطباء النسائية احنا عندنا كثير مرضى بيروحوا على طبيبة النسائية الموضوع البريست لهم they have a role and they are involved with us with some activities والفاميلي ميديسين اللي بيشوفوا المرضى و they refer patients. This is very important issue كمان يعني you should refer physician توقع يبعثوا لك بأي مكان to be educated about screening mammography. Thank you دكتور.
شكرا دكتورة. في أسئلة خاصة بالبرزنتيشن حق دولة قطر. دكتور خالد أنا I noticed إنه incidence of breast cancer is very high 94 per 100,000. البروجرام حقكم involving قطري and non-قطري or only for قطري and this incidence in قطري population?
No, it's Qatari and non-Qatari, and out of the total breast cancer cases, I think 42 or 44, I'm not sure the exact figures, Dr. Hadi, percent are Qataris.
So 1/3 of them Qatari and 2/3 is non-Qatari.
يعني عشان كده السؤال اللي يليه what is the incidence in قطري ladies the breast cancer لأنه هذا alarming يعني كأنكم قراب من أمريكا صاير العدد يعني around 100 which is the incidence in America. We would like to have the يعني إذا في عندكم statistic related to the population of قطر of the يعني قطري people.
Of course we have it. It's طبعا subdivision بس it is alarming because we see these numbers, and again, when I talk about the population, it is a very small population, whether the Qataris or the total population of Qatar. We're talking about 2.4 million. This is the latest. Out of them, of course, there is a lot of men, a lot of working men, and the young men in construction because it's a huge construction site because of the World Cup, and a lot of these people will leave. So again, when the next few years we will see a sharp increase in the number relatively to the population, but then we go back and we subdivide them. Doctor, can we get the numbers?
Yeah, I'm getting it right now.
We are trying to locate the number now. We have it, but because the registry here is for everybody, that's the announcement, and we are using it. It's a tactic. We are using it to scare people, to encourage them to do the screening.
لا بس هو لأنه يعني لما when we notice the Gulf areas and the eastern province of Saudi Arabia, we notice that the incidence of breast cancer in this region, في Gulf region, is higher than if I compare it with the Saudi, the rest of the Saudi. فهل هناك عامل مشترك في الخليج العربي؟ يعني أنا as an academic يعني مخي دائما يشتغل على الريسيرش. So is there a need to make a research and those يعني in the العوامل المشتركة اللي why we are in the who is living around the Gulf have a higher incidence than the rest of the like Saudi country?
I wish there should be a huge unified study for the whole.
يلا أنا وأنت يا دكتور خالد.
أنا ما عندي مشكلة أتبنى أي شيء يعني.
We have to initiate it والله لأنه this is شوية دائما لما أنظر لها أحس إنه يعني البحرين يمنا الانسيدنس higher around 50, الكويت 50 or 55, الإمارات I cannot recall بس إنه أحس إن إحنا كلنا هذا المشترك الانسيدنس is around 50. So what is وإيش العوامل المشتركة؟
إن شاء الله يا رب. بالعكس أنا will be more than happy لما أزورك نقعد we put a plan وهاو to approach it. We will initiate it at different levels يعني من عندنا يعني ممكن نتواصل مع الأخوان في الوزارة ونبوش it. الدكتور ممكن أكلم الدكتور علي الزهراني يتبناها في موضوع الجي سي سي لأنه هو راح يجينا بعد أسبوع أو 10 أيام راح يكون موجود. ففي a lot of things يعني we should start work on it إن شاء الله.
هي برضو عندنا المشكلة في السعودي كانسر يعني ريجستري إنه صحيح according to the regions لكن ال work is not reflected to the according to the numbers. If the fee screening program for certain disease it will be for the whole kingdom. I don't know, maybe أنا عقلي غلط بس أنا I think because السعودية شبه قارة they should concentrate at each region for the المرض اللي عندهم منتشر أكثر. What's applied in الشرقية cannot be applied in جيزان. يعني جيزان الانسيدنس of breast cancer عندهم 13% 13 per 100,000. So أنا this is the way I look at it. ونفسي هالرسالة توصل even لعلي الزهراني أو
دكتورة there was a big discussion لما كنت في الوزارة. There was a big discussion إنه فعلا المملكة قارة وفيها so many hot areas. Why not have center of excellence of a specific disease at certain areas? For example, if we're talking Eastern Province, why don't we have a center of excellence for breast cancer? It's different than, you know, for a center to see 2,000-3,000 and different for a center to see 100 or 120 cases per year. It makes a big difference. And the same thing in other areas. What, yani, you know, in certain areas where you have liver cancer is very high in certain parts of Saudi. You know, all the hepatic and all the biliary, why don't we have a center of excellence at that area? And we start referring. إن شاء الله الواحد يعمل الخير. إن شاء الله
ويدريمه وإن شاء الله حيتحقق. دكتور خالد اللي برضو لقطر ليش الإيج 45 of screening أوكي مع إنه الإيج of incidence of breast cancer عندكم 10 years younger يعني عندنا في نفس السيناريو في السعودية بس إحنا we adopted 40 years. هذا أول شيء. والسؤال الثاني من دكتورة نور تقول على أي أساس سويتوا every 3 years. And that's it for قطر.
ممكن أخلي الدكتور هادي يجاوب على هالسؤال بس I think I know an answer بس تفضل.
شكرا دكتور خالد. So the reason why it started age of 45 it's actually because they may be after finishing the round 2. Round 1 started from 2016-2018. But then we entered the round 2. Then we started COVID. So there is discussion of readjusting, maybe going down at the age. The reason why we started because it was done through actually we had we looked at the previous data because the cancer registry is we have it for I mean we have hospital based before we have country based cancer registry. So based on looking at that data and the incidence from it, we decided on starting 45 and every 3 years. But that's open for reconsideration. And also we have a new system, and I think Dr. She mentioned about how we establish a program. When we are starting screening program, we need to look at the data that we have, the capacity that we have, and take it step by step forward. Combining all of this, you know, I mean, you come up with what feasibility and what's same thing. We could do, let's say, like in the American Cancer Society in the US, they have the recommendation of the high, low dose chest CT scan for lung cancer for a certain number of opportunistic, but that's not been applied in the region that much because of we need to have the infrastructure ready to get this amount of CT scan done. The same kind of ratio. Thank you.
Thank you. في أحد يحب يسأل أي سؤال؟ دكتورة ليلى، دكتورة نجلاء، دكتور خالد، دكتورة نور.
أنا كان عندي نفس السؤال why every 3 years ذكر دكتورة نور كمان إن قطر يعني يمكن the British system they use every 3 years in UK.
Well, we have a mixed system وبعدين يعني you know sometimes certain politics play a role بس إحنا we are fighting from our side يعني in a different way. But definitely we will get to a stage, and I agree with Dr. Fatma, and your question was perfect. And no, why 45 and we have incidence at a very much younger age? Yeah.
From our own experience in Jordan, that I noticed that the gynecologists were following their college, and they were sending women every 2 years. But we were following the ACR, which says every 1 year. So women which usually come after 2 years, they have like interval cancer, more likely to have interval cancers. My experience, but this is not the valid data, that within at least 1 to 1.5 years, a woman should come. This is from our Jordan data. And these were usually lobular carcinomas, which were coming after 2 years. Mm-hmm. So probably, I'm sure that we still have to need more data and research from our region to validate these results.
Yeah,
So,
and based on the
يعني
initial
again-
interval cancer data, that's why we are. I mean, it's not showing the same outcome that happening in Jordan. So the after, if you see the, I mean, in the slide that I presented, the last one, the incidence the cancer interval after 3 years, we are not seeing the same because we are in close contact with Hussein Cancer Foundation and the center of Dr. Jamal. We are seeing the data. I mean, that's the thing. So all this information based, as His Excellency pushed, we are working on the advocacy, and also we are looking at the data itself.
واضح انه في مشاكل مشتركه طبعا بيننا، لان احنا نفس الكلتشر ونفس المنطقه الجغرافيه، لكن يجب ان نعطي كل حق حقه. يعني مصر did a great job مع كل مشاكلهم الفاينانشيال ومع الهيوج number of population، لكن they start to put their foot to do something for the ladies. وكثير عاجبني انه الاعلانات تخططوا الحدود مع مبادره رئيس الجمهوريه المصريه. بالنسبة للأردن، أنا I think الأردن is one of the very good example. نجلاء، أيوة نبي نسمع يا دكتورة نجلاء، تفضلي.
أنا الفيديو بتاعي مقفول، ممكن تفتحوه عشان تشوفوني؟
والله إحنا عايزين نشوفك، أنت افتحيه من عندك. you are an admin.
لا مقفول من عندي، قال لي الهوست disabled. خلاص anyways انا بس عايزه emphasize على الفاليو اوف awareness. احنا لازم نحسن فكر الناس سواء في مصر او في البلاد العربيه كلها. ما زال بنقابل الست، انا الكلام ده عايزه اقوله بالعربي مخصوص يعني.
دكتورة نجلة مش قادرين نشوفك لان انت مش داخله من نفس الايميل، لازم يكون نفس الايميل.
ما زال بنقابل
unfortunately يعني احنا كان نفسنا نشوف الوش الحلو هذا، بس حرمتينا لانك دخلتي من ايميل ثاني. يس دكتوره تكلمي عن الاويرنس، لانه فعلا النمبرز does not reflect الجهد because of the awareness. تفضلي كملي.
لازم الاويرنس يزيد كمان وكمان. يعني وانا بعرض البرزنتيشن قلت ان البرزنتيشن في مصر في الموست ادفانسد كوميونيتيز، يعني لما بنروح نحط الفان في جامعه مثلا جامعه القاهره جامعه عين شمس، بتلاقي البرزنتيشن اوف سكريننج من الستات 30%. يعني الخدمه عندهم وببلاش وفي مكان شغلهم، و30% من الستات بس اللي بيروحوا. يعني يو هاف انك تشتغلي قوي على انك تكوركت اللي في دماغ الستات من ناحيه السكريننج، ان السكريننج لو اكتشفت حاجه مش هيجرى لها حاجه.
هو كان كوركت دماغ الستات يا دكتوره نجلاء. يشمت فينا الدكتور خالد والدكتور اللي معاه.
ايوه هي دي المشكله الاساسيه، المشكله نمبر 1. يعني بالرغم من الفاينانشال بروبلمز اللي عندنا، لكن لو خدنا مثال مثلا ان احنا وي اتشيفد ان احنا نحط عربيه موبايل فان في حته، شوفي كم في المية من الستات مثلا 3000 ست بيشتغلوا مثلا سي في الجامعه، هيجيلك 1000 بس. ليه بقى؟ فين ال2000 التانيين ما بيجوش ليه؟ عشان دماغهم فيها حاجات، انه الماموجرافي في تعرض للاشعه، ان الماموجرافي كتره بيجيب كانسر، ان انا لو اكتشفت حاجه جوزي هيطلقني، ان انا مش عارف لو اكتشفت حاجه هاخد كيماوي. الخوف الرهيب جدا جدا، عدم الثقه في الفاليو بتاعه الايرلي ديتكشن، انه مقارنات مع الاخريات، مقارنات مع امثله في العيله، ومفيش ست زي الثانيه في العالم، ومفيش بريست كانسر زي الثاني. بقى لي 20 سنه بشتغل شفتش حاله زي الثانيه. ما ينفعش بقى تقولي لها ان اللي خدت كيموثيرابي دي وماتت وكذا دي كانت ادفانسد انما انت ايرلي والكلام ده. هم بيقارنوا بحاجات في عيلتهم، وده نوت سبجكت للمقارنه. حاجات كتير جدا، يعني في حاجات كتير جدا لازم نتكلم فيها مع الستات. يعني انت بس علميهم ان دي حاجه مش خطر، وانه كذا، وانه الايرلي ديتكشن هيفيد. عارفه ان احنا بنعمل مجهود جامد جدا جدا في ده، ولكن محتاجين اكتر. الكوميونيتيز بتاعتنا محتاجين اكتر، محتاجين يطمنوا، ومحتاجين يبقوا فاهمين الفاليو بتاعه الكلام ده اكتر من كده. الفاينانشال بروبلمز واي بروبلم طالما بقت الاثوريتي مهتمه، لو في بريزيدنشال درايف خلاص هو هيذلل كل العقبات. انت ممكن كل الفاسيلتيز، كل يعني اجهزه الدوله لما تتضامن مش هتبقي محتاجه فلوس. بمعنى ان انا لو هاخد DSL فري هاخد الانترنت فري، هبعت الصور فري، هاخد كهرباء فري. ده هيوفر كتير من الرن كوست، هيقلل
للأسف الصوت مع دكتورة نجلاء بيقطع، بس أنا I totally agree إنه there is a defect. والديفكت هو أرجع أقول إنه لو في multi disciplinary care ومركز للمرأة كان
لكن انت محتاجه اللي في دماغ الستات، هو ده المشكله الاساسيه في الميدل ايست بس.
تسلمي يا دكتورة نجلاء، الصوت كان بيقطع للأسف في الآخر، بس thank you for your input. أنا أرجع أقول إنه البريست كير is not مهمة الراديولوجيست لحال. التراينجل لازم يكون مؤلف من الناس اللي المفروض يكونوا involved in this care، وهو أهم شيء أنا بالنسبة لي to be organized as فاطمة. primary care should be in the front and we will support them in their mission. والدليل على كلام اللي قالته بروف نجلة إنه أنا I analyzed the 5th year experience والexperience published in the WHO journal. In our experience في 5 years عملنا I think 8000 حالة، 8 سكرينينج يعني. وزي ما قال الدكتور خالد احنا ناقص ندخل على البيت داخل، يعني احنا كنا نروح لهم لجنب بيوتهم we did يعني a lot of effort عشان هم يجوا. لما we analyze the results بعد كده only 3% they come back for the screening، رغم انها السيرفيس ترجع نفس الشيء لعند باب البيت لأقرب primary care center. بس معناته انه it's not only our side اللي قاعدين نودي لهم للبيت السيرفيس، it's all should be done by the support multidisciplinary care. دكاترة البرايم الأوبيغايني they have to encourage ladies and they have to have a big hand in education. وهذا ينطبق مش بس على البريست كانسر، على كل الأمراض السارية في مجتمعاتنا. أنا يعني قبل ما أختم السيشن الأولاني وأشكر، إذا حد عنده أي تعليق عشان نشكر الجميع بعده، تفضلوا.
دكتورة أنا بس راح أقول شيء واحد. يعني طبعا كلنا مرينا في العقبات وما زالت عندنا عقبات وصعاب. يعني مفروض الآن كل هالأمور تتبنى من السلطات العليا. يعني إحنا التكس مثل ما يقولون one incident at a very high level أنه everybody started looking where is the care, why don't we have this, why don't we have this, why don't we have this. فنحتاج أن إحنا بعد نطلع إلى أعلى مستوى، لأن إذا كان يعني أنا بستخدم كلمة أب البيت لأن يعني هم المسؤولين عنا ومسؤولين عن ما يحدث عندنا من تطور أو تقدم. إذا تبنوا هذه الأفكار راح ننتقل إلى مراحل يعني طويلة. هي all what it needs is a will from a higher authority and that's it. Then the ball starts rolling. فإن شاء الله يا رب.
Excellent دكتور، شكرا. Anybody want to comment؟ دكتورة نور، دكتورة ليلى، دكتورة نجلاء. طيب في الختام أنا أتقدم بالشكر الجزيل للدكتورة ليلى على الجهد الكبير اللي شاركتنا فيه، بروف نجلاء على يعني مشاركتها القيمة، الأمير الدكتور وهو مش بس أمير بالبوزيشن، هو أمير بأخلاقه.
طول لي عمرك.
الله، هو زميل عزيز وإيش صحيح أنا أكبر منك دفعة، بس يعني إيش بقول، أنت أمير في كل شيء. شكرا لك وللأستاذ الدكتور اللي شارك معك، دكتورتنا الغالية الدكتورة نور. شكرا لكم جميعا. نختتم الآن الجزء الأول من اللقاء، ملتقانا اليوم اللي I think كلنا استفدنا، وأنا أول واحدة استفدت منكم. شاكرة ومقدرة وجودكم، ونلتقي بعد البريك اللي إن شاء الله على الساعة 2:30. تحياتي للجميع، شاكرة ومقدرة. السلام عليكم. باي باي.
شكرا جزيلا.
السلام عليكم. يعطيكم العافية. ألو يونس. يونس. يونس مرة ثانية، هل تسمعني؟ عيد 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 عيد، ارجع ارجع.